Good morning, all. I thank the organizers for giving me the opportunity to stand and speak here. And life has come a long way, wherein I was mentored by Dr. Raghunath Rao sir. He would not be remembering me. I was one of the first co-batches to be trained for TM exams. So let's proceed with the topic here. Sintilimab is a good and scintillating name. Adding it to chemotherapy for patients with EGFR mutated non-squamous non-small cell lung cancers on progression of the first line TKI. This was an interim analysis study, a beautiful study, so let's go ahead with it. So it's a fully human IgG4 monoclonal antibody, binds to PD-1, blocks the interaction of PD-1 with its ligands, helps to restore endogenous anti-tumor T cell response. Unlike Chinese products, this drug shows promise, and it's a beautiful product coming up, and it's a very small early phase study kind of thing, which has shown promise in the drug itself. Initially, it was used to treat classical HL in patients who have failed 2 lines of therapy, and now it has been extrapolated here. So this is the paper we'll be discussing, the ORIENT 3.1. Interim analysis has been carried out for this. So the origin of the idea. So the idea origin is actually more important. So despite high initial response rate, patients definitely develop resistance to EGFR TKIs within 8 to 19 months. And this was one of the reasons why they went for a combination approach in the subsequent lines. And a little seeding came in from IM-Power 150, although in the last discussion or debate, panel discussion, it was negated that 151 did not show much. But definitely the small subset analysis from IM-Power 150 did prove a seed for this kind of trial. So it was the first large prospective randomized phase 3 trial to investigate a bevacizumab biosimilar combination with sintilimab and chemotherapy. So we all know the mechanism of action. I won't fret on it. It blocks the PD-1 pathway, allowing T cells to recognize and attack cancer cells. A combination with chemo-induced cell death, releasing tumor antigens, further enhancing the tumor response. Then combination therapy promotes a synergistic effect, leading to improved tumor control. Studies show that previous EGFR TKI treatment is associated with changes in tumor microenvironment of EGFR mutated non-small cell lung cancer cells that leads to higher immunogenicity, increased PD-L1 expression, and increased TMB. Furthermore, evidence has shown that VEGF inhibition exerts an immune-enhancing effect. Again, the seed which came earlier. So, sintilimab again is a recombinant drug. Preclinical data has shown its efficacy. There's a small trial that shows efficacy from which they have extrapolated it to the use here in this trial. IBI 305 is a biosimilar which is used in the study along with sintilimab and chemotherapy. So these are the methods. Patients from 18 to 75 years were studied over 52 centers spanning across 3 years of study. The stages studied were stage 3 and 4. Patients were excluded if they had more than 10% squamous histology, CNS mets, previously receiving systemic anti-tumor therapy except EGFR TKI, or have received IO. So they were randomly assigned in a 1:1:1 protocol, wherein the primary arm, or arm A if you call it, had sintilimab, IBI 305 plus chemo. The second arm had PD-1 plus chemo. The third arm had only chemo. The interim analysis primarily assesses the results which we have got from arm A and arm C. So coming to the outcome part, primary endpoint everywhere, which we usually want, is always PFS. Secondary endpoints definitely were OS, ORR, disease control rate, partial response, time to response, and duration of response. So this slide totally shows that 936 patients totally were enrolled. 444 were enrolled and equally segregated. 148 in arm A, 145 in arm B, 151 in arm C. So the next slide, this shows a complete data on a segregated basis. What needs to be noted here is that female population was more when it came to this kind of subset. Second thing which needs to be noted is cases which had never smoked were higher. Third important part which I want to highlight from this table is osimertinib was given to lesser of the population because of the approval of osimertinib being coming late in the country of China per se. And PD-L1 expression was not completely studied in the population assessed. So the result graph here clearly shows that there is a good PFS improvement, 6.9 months versus 4.3 months. And if you can very well appreciate the Kaplan-Meier here. Patients in the first arm had a good PFS. The estimated PFS rate was 59% in the Sintilimab plus VEGF plus chemo arm versus 30% only in the chemotherapy alone group. At 6 months and at 12 months, again, everything was swinging in the arm A favor, that is 28% versus 12%. And there was an independent radiographic review committee to assess the objective response rate, and it was higher in the arm A compared to arm C. The median time to response was 1.4 months in arm A compared to 1.5 months in arm C, that is chemotherapy alone. The ORR was 45% swinging in favor of arm A versus 24% in arm C, that is only chemotherapy arm. Treatment exposure was similar in the Sintilimab plus VEGF plus chemotherapy arm versus chemo alone, and dose intensity was fairly largely maintained. So this is a forest plot, all swinging towards the favor of arm A. I don't think so I need to mention much. Most of it will be discussed further. So adverse events or grade 3 events mostly were concerning marrow suppressions, and treatment-related adverse events, most of them were related to neutropenias and lesser platelet counts, the chemo group usually, and were manageable. It's not that they were not manageable. Immune-related adverse events were also there. Most likely what we usually encounter with our PD-1 blockades is hypothyroidism, and the TSH levels being increased. One more thing was noted, it was studied, was anti-Sintilimab antibodies were detected in few of the patients, and anti-VEGF antibodies were detected in few patients as well. Discussion, arm A was clearly far superior when it came to PFS. Again, the same thing being repeated, and it is in concordance with the small majority studied at IM about 150 trial. Most common adverse effects in the immune-related arm were similar to those usually encountered in PD-L1 inhibitors. The limitations, primarily, just wanted to focus on this for the next 10 seconds. Comparison of PFS between Sintilimab plus chemo and chemotherapy alone groups and OS data were not yet mature and require a longer follow-up. It's an interim analysis. And the proportion of patients who received osimertinib was less, as mentioned earlier. Thirdly, biomarker analysis, including correlation between PD-L1 expression and efficacy, requires further exploration to facilitate better understanding of the mechanism of action with immunotherapy plus anti-VEGFs. Thanks a lot for your patience.